Hello everyone, my name is Brittany Smith. I'm a third-year PhD student in the Exercise Physiology program at Kent State University, and I'm really excited to share my research abstract with you all today entitled Patient-Specific Adaptive Dynamic Cycling is Associated with Improved PD Symptoms. I would like to disclose that my advisor, Dr. Angela Ridgel, who is also an author on this abstract, is an inventor on 2 patents that are related to the technology that was utilized for this research study. If you have any questions regarding the patent, please feel free to reach out. Parkinson's disease, or PD, is the second most common neurodegenerative disorder and is often characterized by the degeneration of the substantia nigra region of the brain, which disrupts dopamine production. Due to the loss of dopamine, individuals with PD often experience symptoms of bradykinesia, tremor, rigidity, postural instability, and cognitive impairment. They also have an increased risk of fall, loss of independence, and reduced quality of life. There are common treatments available for PD, the most common one being the levodopa medication, which is a prescription medication that is converted into dopamine once metabolized in the brain. However, long-term use of levodopa does have some side effects associated with it, and levodopa does not always improve tremor in individuals with PD. Deep brain stimulation, or DBS, is another common form of treatment for individuals with PD. However, this is a surgical procedure that does come along with some risks and complications, and not all individuals with PD are good candidates for this type of treatment. However, high cadence dynamic cycling is emerging in the research as an effective exercise therapy for improving motor symptoms in individuals with PD. High cadence dynamic cycling is performed on the SMART bike, or the Speed Manipulated Adaptive Rehabilitation Therapy bike, which is housed at the Motor Control Laboratory at Kent State University. As you can see in the images here, the SMART bike is a stationary, motorized, semi-recumbent style bicycle that is designed specifically for individuals with Parkinson's disease. It allows for the rider to cycle at a faster pace than they likely would be able to produce on their own. However, the bike also has a dynamic component built into the motor that allows for very slight fluctuations around the set point of cadence that the exercise interventionist chooses during the exercise session. So for example, the exercise interventionist may set 80 RPMs as the cadence for a specific exercise session. However, that dynamic component in the bike actually allows for the speed to vary every second very slightly, anywhere from like 78 to 82, 84 RPMs. And we really believe that this slight fluctuation in speed is what we credit to improving the motor symptoms in individuals with PD. I also want to note too that this cycling is not passive. It does require the rider to produce effort onto the pedals, so it's not the bike doing all of the work. And we do show this with a visual coaching cue of the red hot air balloon over the water. The individual is instructed to maintain the balloon and the basket above the water, and they can do this by producing effort into the pedals while they cycle. If the bike is producing more effort than the rider is, the balloon will actually sink into the water. This type of cycling has been shown to have significant improvements on motor function in individuals with Parkinson's disease, often measured by the UPDRS Motor 3 score, which is a common clinical measure for determining severity of PD symptoms. It's also believed, and our studies have shown, that motor symptom improvement is associated with a higher entropy of cadence or a higher variability of cadence. Therefore, the purpose of this study was to evaluate the effectiveness of 12 sessions of patient-specific adaptive dynamic cycling on motor symptom improvement in individuals with PD. For the methods, we recruited and randomized 23 individuals into our study with Parkinson's disease. 13 of them were randomized into the patient-specific adaptive dynamic cycling group, and the other 10 into the active control group. The mean age of our study population was 72, and the Hoehn-Yahr average stage was 2.22. All participants performed all 12 cycling exercise sessions over a series of 4 weeks, 3 times a week for 4 weeks, typically a Monday, Wednesday, Friday schedule. Each session consisted of a 5-minute warm-up and a 5-minute cool-down at 60 RPMs and a 30-minute exercise session at 80 RPMs. For statistical analysis, we utilized two-way ANOVA and paired samples t-test to explore for differences in UPDRS Motor 3 score. As I mentioned, for the methods, we had two groups in this study, an active control group and a patient-specific adaptive dynamic cycling group. The active control group stayed at a constant resistance level for the entirety of the 12 exercise sessions, while the patient-specific adaptive dynamic cycling group followed an optimization protocol just like the one I have on the slide here. At the end of each week, the raw data for speed and power was pulled from the bike and exported and run through an entropy calculation code, in which we were able to determine the entropy of cadence average over the last week of sessions in addition with effort values. As long as the entropy of cadence and effort fell into the specific ranges that we were hoping for, then the resistance setting would be increased for the following week. We followed a simple paradigm here on the screen. So as I mentioned, as long as the entropy of cadence fell within a specific range from some previously collected data in young healthy people, and as long as effort was greater than 65%, resistance would be increased for the following week. If neither one of those metrics or only one of those metrics was met, we simply followed the flow chart here, where resistance would either be maintained or reduced for the following week. The results showed a significant two-way ANOVA group by time interaction for the UPDRS Motor 3 score. More specifically, those paired samples t-test showed that the patient-specific adaptive dynamic cycling group showed a significant improvement in UPDRS Motor 3 score, while the active control group showed no change. The patient-specific adaptive dynamic cycling group indicated by the blue bars with a reduction in UPDRS Motor 3 score. As I mentioned, this is a clinical score used to determine severity of PD symptoms, so a lower UPDRS Motor 3 score indicates better motor function, while as the active control group did not have any change in their symptoms. Also, interestingly enough, we compared specific dopamine-sensitive symptom responses to less dopamine-sensitive symptoms as well for UPDRS Motor 3 scores. The patient-specific adaptive dynamic cycling group showed a significant 22% improvement in the dopamine-sensitive symptoms of resting tremor, bradykinesia, and rigidity, which was really interesting to see that this type of intervention may truly have a neurophysiological mechanism that is occurring to cause these symptoms, maybe even specifically related to dopamine. We also looked at the less dopamine-sensitive responses and found that the patient-specific adaptive dynamic cycling group had a 7%, however, this was a non-significant improvement in dopamine-less sensitive symptoms of postural tremor, posture, gait, and arising from a chair. In conclusion, we found that 12 sessions of patient-specific adaptive dynamic cycling significantly improved UPDRS Motor 3 score, and optimizing this entropy of cadence was really valuable for motor symptom improvement. So this individualized optimization protocol that we followed seemed to really have an effect compared to staying at a constant resistance setting for the entire intervention. Our plan is to hopefully use these findings to further develop a machine learning or AI algorithm to be able to accurately predict clinical exercise prescriptions for individuals with PD and truly make the bike smart and not have this process be done manually like we did in this study here. However, we are also hoping to investigate specific neurophysiological mechanisms with functional near-infrared spectroscopy in future studies to really hopefully get at the improvements that are occurring as far as blood flow and activation in the brain as a result of this high cadence dynamic cycling. That concludes my presentation today. I would like to thank you all for taking the time to listen to my presentation, and I would be happy to answer any questions that you may have at the email listed here on the slide. Thank you again.